you all for coming, much appreciated. What we're going to talk about today is the Opticare art process. So what is it? It's basically an optimization process of two different components. One is adapting the actual prescription to be the best possible option we've got, and I'll go through the science of that in the next few slides, and then linking that up with the best possible lens designs available so that we can incorporate both of these together to create the best solution in terms of what the patient can wear comfortably and get the best possible outcome. So the process we use for this is basically a Hark-Chapman technique which has been developed over 30 years ago. It basically measures the distortion of light as it travels through the eye and comes out through the cornea. And it actually measures the deviation in each cell in about 300 to 400 different points, depending on the pupil size. And then once we've done this, we then optimize these data points with what we call the Strel ratio. And then we add to that the contrast sensitivity to enable us to create the best possible refraction for that patient. And we also factor in, of course, the pupil size. So the data we use to analyze this is called Zernike polynomials. And the terms we use are basically low order aberration, high order aberration, and what we call the point spread function. And that's basically what we're doing here. We're getting the light from the fovea, it travels through, we measure in each particular point the deviation, and we add all those up to create the prescription we want. So what are Zernike polynomials? You don't need to know, it's not important. The important thing is that you understand is that it's a mathematical process to actually measure the amount of aberrations that we incur, not only in the eye, but in everything in nature. And what we can do is we can break down these deviations in different degrees. Then we analyze that, so each aberration that we have, we can explain in what we call the point spread function. So each one of those aberrations in Zernike can be visually perceived, and the patient can actually, you can show the patient what it looks like. So for each particular polynomial, we have a point spread function, and what we do with this data now, we optimize it using the Strel ratio. So what we do with that is we get the optimum area disk of how the light would be if it's perfect. We take the distorted area disk that you see there, and then we make up the difference. And this is part of the process that we do in the optimization process. So we also factor in here the contrast sensitivity, which is an important factor in trying to ascertain the quality of vision. So we're not just measuring a prescription as such, we're doing a lot of different things, and we're calling all of these things adaptive optics. So we can factor in the age of the patient, the condition of the patient, and we throw that into the mix as well too. What we've done here basically is explain to you the actual measurement process of the eye. And we have a very simple formula, we call it a 4-step formula to actually get that data, to analyze it, and then we can actually create the maps we need for the patient for daytime and nighttime, and then we use the point spread function to analyze it, and then we can tailor make that prescription subjectively, and this is point 4, in 025, 012 or 06 steps. It's up to you. So we can actually do all this with the patient being involved. There's no secrets, there's no hidden magic formula. We're talking to the patient and we can explain this on a very simple basis. Let me give you some examples. This is an example here. Can you see those numbers pretty clearly? So basically this is a guy called Todd, and we did the wavefront refraction on him. The top part there is the conventional refraction, and this is the prescription. PRX is for photopic for daytime, MRX is for mesopic. So the pupil size varies from 3 mil for daytime to 5 mil at night time. And if you look at the prescription difference there, for the right eye, it's very much the same. So we know there's been no change there. Now what this patient actually did, he had LASIK surgery on the left eye only. Because he was over 45 and he wanted to be able to see far away and read at the same time. So very cleverly, he did LASIK on the left eye to make himself short-sighted. So what he did in the left eye, he got his -1 in his left eye for daytime vision. But because of all the distortions from the LASIK surgery, he ended up at night time with almost plano in the left eye. So we have a difference of almost 1 diopter in script. So he was having trouble seeing at night time, as you can see there. So what did we do? So we knew the problem. The beauty of this system is you can analyze the patient's problem in a matter of seconds. You know if you've got a daytime or a nighttime problem, and you've got the prescription to an accuracy of 0.01 steps. We don't need that, but it's good to have as a starting point to do 025 or 012 corrections if you need to. So what did we do with Todd? So basically, and this is now, I showed you the maps of point spread function. Now we're putting that information to life. So we can see that when we correct his left eye, we're just doing the left eye, when we correct the left eye, his prescription with conventional refraction is actually very, very distorted. He sees the point of light, not as a point of light, but as 2 flares coming out. And what we did with the nighttime script is actually give him that point spread function. And that's the same information on a Snellen chart, exactly the same information. Case study number 2. This was a 4th year student from the Canberra University, and he actually ended up chatting to an old colleague of mine who worked for me years ago, and she's working there now. And she suggested that he come and have a chat with us and try and help him. And in this particular case, he had LASIK surgery about 20 plus years ago, and ever since that, he's never been able to drive at night time. So to be able to drive at night time, he had to put drops in his eyes to be able to drive at night time. This is his results. And that's the glasses he was wearing for daytime. We do the art refraction. We end up with a daytime script of minus 0.17. We end up with a nighttime script of minus 1.25. So we know why he's having a trouble. We can measure it. And there is no other way you can measure this unless you use wavefront refraction. Very similar with the left eye. Daytime, virtually planar with 1D seal, which is what he's wearing now. But for nighttime, we ended up with a minus 1.25 sphere for his nighttime vision. So basically, what we did for him was very simple. That's the vision he was getting, point spread function. That's the vision he's getting. Now, the beauty of this is you can actually show this to the patient while he's with you in the consulting room. That's what he's seeing at nighttime through his conventional prescription. As soon as we give him the new prescription, the nighttime, we end up giving him -1 with almost a minus 2D seal. That's what he's seeing now. So he ended up getting 2 pairs of glasses. One was like his old pair of glasses he had. We virtually gave him a totally different pair of glasses for his nighttime driving. And this is an email that he sent me. I've quoted him word for word, and I have his permission to use his email. He said, I've just tried these lenses and they work really well. I'm very happy with them and can't wait to tell Layal, which is great. And basically the important thing now is he's not afraid to drive anymore. And to me, that's magic. I mean, we've got a tool here that we can analyze and predict what's going to happen. And there's no other way you can do it unless you do wavefront refraction. So I don't care how you do it, where you do it, but doing wavefront refraction as a starting point for your diagnosis is imperative and critical to really understand your patient's vision. You can't call yourself an optometrist unless you understand the patient's vision, daytime, nighttime, and correcting that prescription to the nth degree that you can. Okay, 0.06 is a bit of a push, but doing 0.12 should be no problem at all. So it's really, really important to be able to explain to the patient that as well too. And we can do it so easily now. I mean, as an optometrist, if you told me this when I graduated, I would have said you're dreaming. There's no way that I can understand how a patient's going to see and be able to sit down on a screen and explain it to them. We can do it today, and we should be doing it today. We've covered the first part in terms of doing the eye tests. The second critical part is understanding lenses, because we want to give that patient, now that we've given him the best eye test, we want to give him lenses to suit. Now, as you know, with freeform lenses, they're actually made or manufactured in a similar way to we do the wavefront refraction. We have points, digital manufacturing, so there's a lot in common between the two processes. So what we can do now is we can actually manufacture the prescription to an accuracy of the glasses to an accuracy of 0.01 diopters, whereas compared to the old days, with using lathes and tools to manufacture lenses, we were looking at about 0.12. So we have the ability now to manufacture lenses to an accuracy that, again, 30 years ago, it wasn't possible. So what we've got now, we can factor in not only point for point, but we can factor in the frame wrap, the panoscopic tilt, the vertex distance, and we take into account the pupil centers, and the heights are critical as well. And we've got improved algorithms to reduce the distortions now with better designs, and so we can get better visual zones. Very important. So to understand digital lenses, you need to know two things. One is what we call a cylinder map and a power map. And very simply explained, the cylinder map is the amount of unwanted cylinder that you get in a lens to create the power you want for that particular script. And what you aim for is the least amount of cylinder in a lens design to give the patient maximum fields of view for distance, intermediate and near. So what we want to do is keep the cylinder as low as we can, and we want to keep the distortions as low as we can. And we want to control where the distortions are. So basically, the good things to look out for is a lens that has straight lines. So this lens map here has got a lot of wavy lines, which will cause waves for the patient. So that's interpreted to the patient as a haze, as a wave. If you give them a design which has got a straighter line, it'll feel better to the patient, it'll give him a smooth transition. So we have good lens, bad lens. That's right, that's the power map. I cheated there. What we need to look for in there as well too is the spacing between the contours. We want them to be consistent, which are not too bad there. We also want to have the largest consistent areas. That's important. So we want this area to be as large as possible, but we need to be consistent. In this case, we're not very consistent because we want that orange to be all over here, and it's not. The map next to it is the power map. So this is the actual power of the lens. So what we need the clearest part, the least unwanted cylinder, to marry up with the best power map there. That's the aim of the game. So to explain that a bit easier, what I've done is I've created what I've called a hybrid map. So all these maps are based on real lenses, plane out of 2. This is the ultra clear lens that we have. So you can see here the unwanted cylinder map. Now we can usually adapt to unwanted cylinder of about 0.5 diopters. So the white area there represents the clear zone, which is unwanted cylinder. We've balanced the cylinder off on both sides. So when you look temporally and nasally, each eye is looking through the same distortion, which is very important. And we've got minimum cylinder here. It's about 1.4. So what we do now is we take the cylinder map, we put it on top of the power map, and you end up with the hybrid map. So what happens here is, this contour dot in here is where we can see clear vision. And as you can see, our distance vision is really good. That's our plano, that's our 025, 050. So we're getting a good corridor, nice wide vision, and our reading opens up dramatically. So that's, I would say, one of the best lenses that I've ever designed, and that's available today. And to make it a little bit clearer, that's what it looks like. So you can see, this is, in terms of lens design, one that's very hard to beat, and Opticare is very proud of it. And within that, we have a lot of lens ranges. I won't too much time on this. So basically, we've got a whole suite of lenses that fit into this category. Very low contour, a very low distortion, have very wide distance reading or intermediate areas, depending on the design you select. And we have a lot of options there. I'll mention too the behavioural side of things. We have a lens now as well, for lens designs where you can actually control your distance PD, and you can inset the near PD to whatever you want for each eye monocularly between 0 and 4 millimeters, which is quite an interesting option to have. And that's one of our lenses looks like. So very neat, very clean, always balanced. All of our lens designs are balanced. So when you're looking temporally and nasally, the lenses look very clear. And in terms of what's available on the market, I would say we are one of the best out there. And the only way to prove it is to give them a go. So basically, what we need to do, the next step is how do we integrate this into our practice? We had this discussion a little bit earlier with someone who's here today, because the challenge is you need your staff to be on board. And Joe should be giving this talk, not me, but that's okay, I'll go through it very briefly. So what we need to do is integrate this into your store. And how do we do it? We've got to make the patient realise that what you're doing for them is special. What you're giving them is not an ordinary eye test. You're giving them something that's unique, and something that they won't get anywhere else. And what we need to do is train your staff as well to be on the same page as the optometrist. So the optometrist does the interpretation and the explanation, but the staff needs to be on side to be able to carry that through and project it to the patient. So we're here to help you do all those steps, and we're happy to chat to you about those steps as well too, but they are critical for this to work in your practice. You can't just say, okay, I want it and do it. We've got to go through the journey and explain it to you, and getting you on the right steps to do it. And we can go through all that with you as well too. It's a whole process. It's not just a matter of getting the glass. As I said, we can help you with a lot of things, with the marketing side of it as well too. We can help you in every step, because we need to train your staff. Not only when you do the first impression, you need to get the appreciation they're getting something special. We need to basically do the eye test with the optometrist. Then the dispensing side is super critical. That must be done perfectly well. And when they pick up their glasses, they're not just picking up a pair of glasses, they're picking up something super special. You've got to basically make that patient, and I've said this since I graduated in 1980, the most important way to market your product is the patient who walks into your practice. If you treat them like a king and a queen, you've got them on side and they will appreciate it. And what we're doing now, we're actually giving them a quality product and quality lenses like they were kings and queens. So we can do this, and the important thing is that we've got to impress them with what we've done, because we want them to tell their friends. And to me, this is very, very important, and as good as marketing. And of course, we can help you. This is just some of the flyers we can do for you. We can create your marketing material for your store. We can create different types of promotional material. in terms of on the wall, on your window shop, little counter displays as well too there. Oh, next slide. Sorry, not there. Yep, counter displays as well too. So we can help you with the marketing side so that you can get that message across how important this product is to your patient.